So next one is pre-gestational diabetes mellitus. So in pre-gestational diabetes mellitus, acanthosis nigricans will occur, which means it is a skin condition in which there will be a velvet patches around the body folds. So it usually seen in obese and diabetes mellitus patient. So this is acanthosis nigricans. So next we are going to see types. In pre-gestational diabetes mellitus, type 1. So here it will be a hypoglycemia, starvation. So starvation will lead to ketosis. And next one is type 2. So in type 2, hyperglycemia will present. So hyperglycemia will lead to ketonemia, acidonemia. Okay, next one is T3. So in T3, hypoglycemia and ketosis will be present. So these all about pre-gestational. So these all about pre-gestational diabetes mellitus. Next we are going to see about pathophysiology. Due to fetal demand during pregnancy, during late pregnancy. So it will lead to maternal nutrition indigestion. Which induces greater, more sustained level of blood glucose level. And it will lead to maternal insulin resistance. Also increases. It will maternal insulin resistance also increases due to insulin antagonist. Effects from the hormone. Okay, so it will lead to maternal insulin demand. It increases threefold. So it will lead to majority capable to increase the production and compensate insulin. Insulin resistance, and it will maintain normoglycemia. So it leads to pancreas unable to produce the insulin. So it leads to pancreas unable to produce insulin, or insulin is not ineffective. It's not effective. So it all leads to gestational diabetes mellitus. So due to gestational diabetes mellitus, there will be excessive thirst, hunger, and increased urination, and also weakness. So this is the pathophysiology and also weakness. So this is the pathophysiology of gestational diabetes mellitus. Next we are going to see investigations or diagnosis. First one is history collection. So in history collection we have to collect the family history, whether there may be any family history of gestational diabetes mellitus. And also in physical examination we are going to check obesity. So next one is blood investigation. And next we are going to see fasting plasma. Fasting plasma glucose level, it should be 126 mg by dl. And next 2 hours 200 mg by dl after a 75 gram of glucose blood. So now we are going to see two-step approach. So in two-step approach, first we are going to give 50 gram of oral glucose. So we have, after 50 gram of oral glucose, we are going to check 1 hour. So it should be 130 mg by dl. So it is oral glucose tolerance test. So after glucose tolerance test, the value should be 105 mg by dl fasting. If it is 1 hour, 190 mg by dl, and 165 and 145. So if the test is positive, if 2 or more of the followed values are met or exceeded, if one value is elevated, the 3 hour, which is 100 gram glucose tolerance test, is repeated at 32 weeks of pregnancy. Okay, so next we are going to see effects of diabetes mellitus in pregnancy. First one is spontaneous abortion. So and next one is preterm labor. And third one is diabetic ketoacidosis. And fourth one is infection. And next one is polyhydramnios. And next one is PPH, which is postpartum hemorrhage. And next one is increased operative delivery. Increased operative delivery. Next one is polyhydramnios. Polyhydramnios means it is increased amniotic fluid. Okay. So next one is hypoglycemia. Okay. So next we are going to see what are the effects on fetal and neonates. So first one is hypoglycemia. And next one is hyperglycemia. And next one is macrosomia. Macrosomia means big baby. Okay. Next one is growth restriction. And next one is congenital defects. And next one is fetal death. So these are the effects of DM in pregnancy, fetal and also neonatal.